The broadcast is now starting. All attendees are in listen-only mode.
So good morning, everybody. Welcome to our EAO webinar on when elder abuse is suspected in hospitals, the importance of policies and procedures. We are going to get started in about 1 minute. We do have people that are logging on as we are speaking. So I'm just going to just leave it for a couple minutes, but just so you know that everybody will be muted through the entire presentation. If you have a question before we begin or during, you can put that in the chat box, or you can put it in the question box along the side of your dashboard. So I'm just going to wait 1 more minute and then we can start the presentation. Just so everybody knows as well that the presentation materials will be posted on EAO website, and also in the handout section on your panel there's also 4 documents that relate to the webinar, including the PowerPoint presentation and other supporting documents including the policies and procedures from Southlake. So I think what we'll do is get started. It is 11 o'clock and I know other people only have a limited time. So welcome to our webinar. I'm pleased to work in collaboration with both Susan Steeles and Annie Hayward from Southlake Regional Healthcare Center, and they are going to do our presentation today. So I just have a few housekeeping things that we need to cover in regards to the presentation. If you could just go to the next slide, Susan. So as I indicated, everybody will be muted through the entire webinar just so it can be recorded. I talked about the chat box and the questions. It does come up as Mary Mead or Rayanne Rideout, and so it is the same person. It's just that the sign in for us has both names. There will be questions at the end for questions and answer. If people have those, I will be moderating that session, and then Susan and Annie can provide some answers to those questions. There will be also an evaluation form at the end. After the webinar is completed, you'll get an email pop-up box. We'd really appreciate your feedback. It does help us determine if we're providing accurate information and training to our stakeholders, as well as getting information about our future topics and discussions that we can do. The contact information for both of our speakers is at the end of the presentation, so if you have any questions and you want to contact them directly, they do have their email as well in that in the slides. Also during the presentation we do have a couple polls that we want to ask you just to get a sense of who's here and how many people have policies, so we'll talk about that in a second. Let me just go to the next slide. So those who are new to our webinars and maybe not familiar with Elder Abuse Ontario, we are a provincial organization. We're a nonprofit organization whose mission is to ensure that seniors are free from abuse, and we work through that, trying to educate people through awareness, education, training, collaboration, and service coordination and advocacy. In 2002, we had worked with our Ontario government to implement the Ontario strategy to combat elder abuse, and we continue to do that today. And we are working across the province in terms of implementing that strategy in various forms. There's 7 regional consultants, so I know many of you attending today are from various regions throughout Ontario. So if you aren't sure who your regional consultant in your area, you can go to our elder abuse website, and there is a listing of the staff and the regions that they do support. So if you want further information, you can contact them there. The next slide. So this is a really good example, this webinar, of our collaboration with community partners. So I've worked with both Susan and Annie for some time in my region in York, and know that the good work that they have done. So also recognition of other areas that I've worked with. I know that the development of hospital policies is a really important issue that many people are interested in developing, or if not editing, those that they already exist or adapting. So I really want to thank them today for sharing their expertise with us and you today as we go through this, because I think it's such an important issue that we need to address. So as I mentioned, Susan Steeles, she's the presenter, one of the presenters today. She is a clinical educator with the geriatric outreach team and the professional practice leader for social work at Southlake. And Annie Hayward is a geriatric emergency management or GEM nurse at Southlake Regional Center. Both have worked for many years with seniors in acute care and are actively involved with their local network of elder abuse known as the Prevention of Elder Abuse Committee York Region. So I know they have a lot of expertise that they're able to share with us today, and I'm going to turn it over to them to start the presentation. Before I do that, I do want to have a quick poll as people keep coming on. We wanted just to get a sense of what sectors people work in that are on the webinar today. So I'm just going to post a quick poll, and if you can just take a few seconds just to click on the sector that you work in, and then we can sort of get an idea of sort of who's on the line, and then that help the presenters in terms of how they target that information as well to individuals. So I'm just going to close the poll. So everybody's had a chance to vote. It's kind of going up and down. So I'm just going to close that. So what we have from the results is 51% of the attendees today are from hospital, 37% are from community health and support agencies, 11% from CCACs. And this is really important, I think, as we talk about community collaboration in response to elder abuse, because as we both know, hospitals are a short-term stay, and we have to work with our community partners, particularly our home care and CCAC, upon discharge for individuals. So it's good that we have a really good representation from that as well. So we just have we have 3 little polls that we want to ask, just the initial. And the second one is around if people have an elder abuse policy currently within their agency or hospital organization. Or you could be in progress. So it's either yes, no, or in progress. So the results indicate that 69% actually have a policy, 22% don't, and there's 9% who are in the process of developing one, which is really interesting. So as we go through this, you could be able to compare your policy with Southlake, as well as maybe even learn how we could maybe adapt or incorporate from one another's experiences. And the last one we just wanted to ask was around your level of confidence in responding to elder abuse right now, based on your experience and your outreach with working with seniors and your profession. So just looking at that very quickly, 15% very confident, 47% said confident, and 38% said somewhat confident. So that's great. Thank you so much for participating. I'm going to now turn it over to the presenters to take over and talk about their presentation. Thank you.
Good morning, everyone. It's Annie here, and just wanted to say thank you very much for attending this morning. It is our pleasure, Susan and I both, to be here today to discuss our journey on developing a policy and procedure for elder abuse at our hospital. And a quick thank you to Elder Abuse Ontario and Rayanne for recognizing that others in the community would be interested in sharing this knowledge. And we would like to preface this talk by stating up front that we were very fortunate to draw on many experts as we moved through this process, and we will be going into more detail about that. So our objectives today are to describe our journey towards establishing a policy and procedure to respond to elder abuse in the acute care setting in our hospital, and address some of the barriers to getting a policy and procedure into our administrative manual. And then the meat of this talk will be actually walking through that policy and procedure, and I think that's perhaps where you will have questions and certainly be trying to figure out how it all works. So here we go. Okay. So the journey, and establishing a policy and procedure in the hospital was very much a journey. We wanted to make sure that we had due process to everything that we thought was going to be important to inform a document that was well written and that was respected by our peers, and that really spoke to the needs of the people and honor the decisions that the people that we work with and the stories that we hear in healthcare. So the expansion really started with the expansion of the specialized geriatric services in the Central Lynn. So in 2007 to 2009, there was money put into the expansion of SGS services. Specifically, we had GEM nurses and geriatric outreach teams created. And within the mandate of both of those professional groups, there was a responsibility for capacity building. And with that, we had the resources and the champions to join our community partners. And we chose to do that, both Annie and I chose to do that by joining the Prevention of Elder Abuse Network. Along with that, we saw the gathering of professional information. So we thought if we were going to write a document, we wanted to make sure that it was reflective of best practices. So we embarked on literature review, speaking with our expert people, looking at what the professional colleges were saying about elder abuse prevention. A big part of that journey was that there was a growing public awareness, and there was the introduction of new legislation that specifically targeted what our responsibilities was and what our accountability is for elder abuse. So we really felt that we had good support externally, and we needed to build also the same type of support internally, because navigating the hospital policy and procedure route would be complicated. We chose to navigate through the Senior Friendly Hospital Committee, so both Annie and I were members of that committee, and we built our champions around the hospital committee. And through the conversation, we would come up with responses such as, why do you really need this? And so to create a common message so that our champions could carry, we created a document called Why Southlake Needs a Policy and Procedure. And that was sort of our little handbook. And as we walk through the presentation, you will see where some of those statements come out. So together we actually drafted a straw dog, as it were, and first draft was developed through the Senior Friendly Hospital Advisory Committee, as Susan said, and then that same month actually we used this first draft and we took it to our community partners at the Prevention of Elder Abuse Committee, York Region. And what we did was we actually had a workshop that was attended by both hospital and community partners, and some of those partners included actually the seniors. Those seniors could be from volunteers, they were sometimes from CARP, the Association for Retired Persons, to get their feedback. And from that feedback, then we were able to rework the document and actually bring it back to the hospital. Okay, so moving back to the hospital, we came back to the hospital with a draft policy and procedure that had been created by seniors, our community partners, and our other partners in hospital and healthcare. Now we had to move through the structure of policy and procedures, which in our hospital is called Clarity. To even get your foot in the door, we needed a management sponsor. We were very fortunate that Roz Gamble, our manager, was very much a champion of elder abuse prevention, so she immediately came on board and offered to sponsor the policy and procedure. Then we had to move through the committees. So these are committees that all hospitals have. So you have like committees that are required, that you're required to move through, and then we have people and experts that we want their feedback. So we identified the committees we were required to move through, and we also identified people that we wanted to review this document, and that would include the social work professional practice group, the
the ethicist, and other individuals that were passionate about senior care at Southlake. Once we got into that system, we would get feedback, and we had to rewrite based on the recommendations of the reviewers. There's potential to get caught up in that world for months and if not years. What really helped us get the final approval was that we were also going through accreditation, and what was very important to our hospital was violence prevention and staff safety, and that was, they were also writing policies and procedures around that. So as I started to move through the system, the people looking at it said, wow, this is a really great and well-written procedure. Can you be the template for all of these other policies and procedures? And of course we said absolutely, and then we were fast-tracked. Nobody could move until we had ours approved, and that really elevated us, and within no time we were on the policy and procedure manual.
And this is what it looks like on our intranet. So there is a search button there that you can sort of see up on the top right-hand side, and when you first, obviously prior to this, if you searched for elder abuse, you wouldn't get anything, but if you had typed in abuse, you would see something around abuse as it would relate to the abuse of a patient by a healthcare worker. So that was the only thing that would come up in that search button prior to this. And now we're going to walk you through each section and let you examine the content. So this is the header of that policy, and I'm sure you all would recognize this, something similar in your own organizations. And it identifies which manual it's in the administrative manual, and it also tells you about the authoring committee here. What's important to note here is that we tied this in again to the organizational values around no tolerance for violence, and this was very intentional on our part because we were very mindful of connecting this to the strategic plan of the hospital, and that of course provided the leverage we needed and made it important for everyone, and particularly for those reviewers. And again, you can see that abusive patients down at the bottom there. That was, if you had typed in that search button, that was the policy that you would actually have picked up. And again, it was around abuse by the healthcare professional only. There was a list of cross-references, and we embedded a lot of these as hyperlinks into the policy and the procedure, because at the end of the day, when we actually did do our inquiry and looked at other people's existing policies and procedures, they were huge, really, really bulky. So the ability to hyperlink reduced that bulk and made the document just seem like it would be more manageable for someone to be able to just target what they wanted to know and then move through and hit a hyperlink if they wanted more information. And so you can see there's a variety of them there, including police investigations and violence risk assessment and so forth. We've lost her. Let's see. Oh, there we go. Okay. So the definitions. This was interesting. We did want to use the World Health Organization's definition of elder abuse, and the reviewers did accept that definition. What we got feedback from the reviewers is they really wanted an age. So they wanted, people were looking for clarity on what age we were getting at when we talked about elder abuse. So we worked around that by saying that it would be 60 plus, which was in keeping with some of the specialized geriatric services definitions. And we also included that it would be an adult who is dependent on another adult to provide physical, emotional, and/or financial support to maintain wellness. And for staff, we wanted the policy and procedure to be include anybody. So it was everybody's responsibility if they saw elder abuse, that they would be part of the reporting structure. And with that builds into our value that it is a team approach. So the rationale here really was the key. We needed people to understand why this policy and procedure was important, so this was really our selling point as it moved through the various committees. And it helped to validate the need for having a policy and procedure in the first place. We did expect actually that this rationale would be ultimately pared down, changed, or altered, and we were quite surprised to find out that it actually remained relatively untouched. We wrote this with a very specific lens, and that would have been of the social determinants of health rather than with a medical lens. And this was maintained throughout. So we were really asking the question why we needed this policy and procedure. And so our answers were the abuse and neglect of vulnerable seniors negatively impacts health status, and that's key. Because that's really what makes this very different than just sort of domestic violence, that there's a huge impact on their health status, and that's not necessarily the case in the case of domestic violence, but certainly with frail seniors it is. Abuse and or neglect can be associated with the need for urgent medical or psychosocial interventions, and then when the seniors come to hospital, elder abuse may be disclosed or suspected by any member. So again, that interprofessional approach, and that everyone has a responsibility and accountability. Acute care hospitals can be where abuse and neglect are identified for the first time or suspected of being inadequately addressed prior to admission. Pre-existing cognitive impairment and acute onset cognitive changes. So here we were looking at delirium, can negatively impact the person's ability to self-disclose abuse or neglect, and therefore the healthcare professional must identify, document, and act where there is suspicion of abuse or neglect. And the interesting thing is we did put in here admission to hospital may be required. So acute care hospitals in general try not to admit patients if they don't have to, but they did recognize the need for patients that may require the hospital as a safe haven, as a last resort. And admission also may be required to optimize their health, address that delirium, and so forth, to provide a comprehensive assessment and develop a sustainable discharge plan in collaboration with our community partners. And the other reason was that there were these acts, the Long-Term Care Home Act and the Retirement Home Act, which made it mandatory to report elder abuse for patients residing in these facilities.
So these headlines are standard headlines for every policy and procedure. So these were more of a fill in the gap for working through the process. The method, and again, this was a standard need to explain. So when we looked at method, we wanted to be very specific that there was no general duty to report crime to police, and unless there was an imminent risk, it would be a breach of a patient's confidentiality to report crime learned through the course of providing health care. And we wanted to hyperlink that guideline for informing, providing information to the police. But specifically, though, there was mandatory reporting for some populations, and that was not understood well in healthcare. So people may have known that there was mandatory reporting, but they didn't understand who the reporting body was or what the phone numbers were. We also wanted to highlight that professionals are responsible to colleges and codes of ethics, and furthermore that the Office of the Public Guardian and Trustee has a responsibility to investigate abuse involving adults who they believe to be mentally incapable and at risk of suffering from serious harm. And this also gave us the opportunity to hyperlink it with the Substitute Decisions Making Act, so we could link people up to that act without including all of that act in this specific policy and procedure.
So this is actually the breaking down of the steps then. So we start off with any staff member, and we've already outlined who that could be, who suspects elder abuse or is told of an incident of elder abuse or witnesses elder abuse of a patient, that they would inform the unit-specific manager or designate as soon as possible. If the staff member is a healthcare professional, then they would use the EASY tool, which we included in our appendix. and when elder abuse is suspected, and document the findings in the medical chart. The other thing that we included was, of course, that mandatory reporting, so that if the patient was identified belonging to a retirement home or a long-term care home, then we showed them where they actually had to do the reporting, depending on where they were from. We made a note of indicating that if the staff member was not a healthcare professional, so here we're thinking of, you know, a volunteer or someone from an allied health who may not have direct linkage to the chart, the unit-specific manager or designate would be responsible for ensuring that the above steps were completed. Okay. So we recognize that although elder abuse response is team-based approach, that the procedure needed a recognized professional who was accountable to lead the process. So we were very specific that the manager or the designate would identify the appropriate healthcare professional to work in collaboration with the patient to assess, plan, and implement a response to the elder abuse. In the emergency department, we wanted to target that a referral would be made to the GEM nurse, and on the inpatient unit, we wanted to target that a referral would be made to a social worker, and if there was not a social worker on that unit, that it was the manager's responsibility to designate someone to act in that capacity. Again, we wrote that the unit-specific manager or designate would inform risk management, security, the director of the unit, and patient relations as appropriate. So again, complicated situations, we wanted to make sure that we highlighted for the reader some of the other people that they may need to contact to promote a safe environment for both the healthcare workers and the patients that were in our care. So, now we get into capacity. We could write many, many pages on capacity, and we chose to hyperlink capacity with other documents in our policy and procedure manual so that we could really target elder abuse. The statements here on mental capacity, the underlying values are respect for autonomy and self-determination and dignity for the people that we are working with. So those are the underlying values. So when we're working with people who are mentally capable, we wanted to be very specific that the social worker / GEM or the designate will work with the patient to identify their priorities and their needs and their preferences. And they would be in charge of making the decisions around how they were going to respond in their own life. The healthcare professional will inquire whether the patient's wishes their family or significant others to be informed. Again, recognizing that seniors and work often within the context of their family, and they often love their family, even if they are the abuser. So we wanted to make sure that we honor the patients who are capable. We want to honor their wishes. If requested by the patient, we would work with the patient and their family as soon as possible, as appropriate to the situation. Again, we needed to be appropriate to this situation with a lens to ensuring the safety and security of the environment that we work in. We said that prior to discharge, information and support will be provided and safety planning will be established. So with the patient or the substitute decision maker's consent, this may include a referral to the York Region Senior Safety Officer. So we wanted that phone number in there for people who wanted to access that support. And we also were mindful that even though the patient may be capable, often when you're in stress, even a capable person will want to defer or may choose to defer their decisions to a substitute decision maker. So again, it's respecting that capable person's right to make those choices. For patients not from a long-term care home, with patient's consent, information would be shared with community providers. While the patient was within the hospital, we would be sharing information. However, on discharge, we would honor their need to consent if we were going to share their information with community providers. Okay. And then we enter the murky waters of the incapable person. So I'm sure as many of you know that capacity is based on that ability to understand and appreciate the consequences of an action or an inaction. And we cross-referenced this with our policy and procedure on substitute decision makers and slash POAs. So the idea here is whether they were able to make an informed decision. The key for us is that we actually targeted safety planning. So as you are all aware, there's no such thing as sort of global incapacity, particularly when you get into a setting of cognitive impairment where they may be able to understand and appreciate some things and not others. So just like CCAC, they target, does this person have the capacity to, agree to a long-term care home? This policy and procedure, we focus specifically on safety planning, and so we'll move through that. So we've got the physician in collaboration with the interprofessional healthcare team will address and redress reversible causes of mental incapacity. So here we are looking at delirium specifically, and we know that certainly the sequela to elder abuse can include things like dehydration, poor nutritional status, and we have to try and optimize those healthcare needs to try and improve the patient's ability to self-determine and to be involved and provide that informed consent to the best of their ability. Where there is benefit to the patient and minimal risk to the healthcare professional, designate whoever it would be, we would engage the patient's power of attorney or substitute decision maker to assess the suspicions of elder abuse. Now, that being said, we recognize that that person could potentially be the abuser, but we have to start somewhere, and so we have to start building that information, and if the patient isn't capable of giving us that information, often we start with that power of attorney and substitute decision maker, which doesn't exclude anyone else that might be involved with that patient and know that patient. If the power of attorney or substitute decision maker is suspected of being the abuser, or there is concern that the individual isn't acting in that patient's best interest, then we indicate that you need to contact the public guardian and trustee. The elder abuse assessment and response involves that interprofessional team approach. And here it was important because we were talking about the fact that we included here ethics, because ethics actually can provide a great way of looking at a situation, looking at the values involved, and trying to help strategize around potential plans that would focus the discharge.
Okay, so here we embedded how to contact the Office of the Public Guardian and Trustee, and we embedded the Substitute Decisions Making Act and the Personal Health Information Act, which talks about privacy. Then we included, for the purposes of discharge planning, we wanted to include how to plan for emergency shelters. We put that patients who do not require acute care and are at risk of serious harm will be supported to relocate to a safe shelter upon discharge. Again, we have some accountability here to our patients and our community partners and to work towards planning a safe discharge. The discharge planner or the patient flow coordinator, whoever's performing in that role, will work with the patient and community to identify emergency shelters. For the patients requiring supportive care, we will work with CCAC to determine eligibility for long-term care and coordinate that emergency shelter. And for patients who are capable and making an informed decision to return to a situation where there's serious harm is suspected, that we will document the details, including the resources provided and the discharge destination.
And then we move into documentation, which we wanted to be very specific here, keeping in mind that documentation could be later used in a court of law. and actually could be used for sentencing under Bill C-65. So we indicate that healthcare professionals have to document what was witnessed, reported, suspected in the patient's healthcare record if they had access to it, and if they didn't, then the designate would do that. The second point here is that if the patient is capable and doesn't fall under the two specific acts, then permission to share that information with other healthcare providers will be established. So here we're getting at the fact that we don't need consent from the patient to document in their chart. We know that elder abuse impacts their clinical presentation. That's important for all caregivers looking after that particular patient, and so there has to be documentation so that we're accountable and responsible as we care for this individual. And we recognize that we have to address those social determinants of health. But in the case of a capable patient, sharing that information outside of that hospital visit does require consent, i.e. that circle of care. And certainly we would encourage these patients to, allow the family doctor to know what's going on, or perhaps their community care providers. But ultimately it becomes their decision, and they have the right to refuse to share that information. 3 is the disclosure of patient information without consent, or as required by law, is defined as an act of professional misconduct. So it was just to be mindful, the staff that were reading this, that they did have a professional responsibility here. And we link that again with the police investigations guideline for staff. And that 4th one is if a civil suit was brought forward, that's when documentation can be key. So the person who made the report would be protected. So this is sort of your standard whistleblowing policy, and we actually drew on other policies when we took the wording here about the fact that that person would be protected unless they were seen as acting maliciously or without reasonable grounds. And then that's it. We referenced everything that we had talked about or included in the policy and procedure. And then we added our EASY tool at the end as an appendix. And you wanted to mention why we had chosen the EASY tool, Susan?
Okay, so we chose the EASY tool because it was a tool that was developed here in Canada, and it was also recognized most recently by the physicians, Canadian Family Physicians, in their journal of being the tool that they would use if elder abuse was suspected. And it leverages what other really important partners in care see as important. So this is it is very quick and easy to administer. So when we then, at the end of the day, we all patted each other on the back. We celebrated our patients, our community, the seniors that were part of this journey. We're really pleased that we got this on the hospital administration manual. And then we thought, okay, but did we target the questions that our healthcare providers really wanted us to address? So specifically, they were like, how do you start a conversation? Can I call the police? What is mandatory? I hear that elder abuse reporting is mandatory, but what is mandatory, and who do I call? How do I act? Who takes the lead in the absence of social work? When does the Office of the Public Guardian and Trustee get involved? And they didn't, it was really difficult in a crisis to pull all of the answers to these questions together. How do I document? Do I document? And a big question in acute care is, do we need to admit? Do we need to admit someone who specifically because of elder abuse? And these are the answers that we came up with through our policy and procedure. The EASY tool was established as a best practice for starting the conversation. We focused on what is legislated and that there is no duty to report crime. However, there is some legislation that does require us to report, and we were able to target specifically who we reported to. We focused on the procedure as being an interprofessional responsibility with the social worker, GEM nurse/designate to negotiate the lead. This point focuses on the fact that somebody needs to take the lead. Even though elder abuse intervention is a team approach, someone is accountable for taking the lead, and as an organization we must make that happen. The procedure spells out when and how to contact the Office of the Public Guardian and Trustee, so you're not Google searching and are going into other policies and procedures to figure it out. It clearly states that planning emergency shelter is an organizational responsibility, and the acute care hospital has a role to play. I think we were able to really drive home this point by, in our rationale, pointing out that physical, mental, and psychological health status has impacts elders greatly, and they do become sick, and they will end up in the emergency department, and and they need to come to the emergency department. But if you want to really get at the root cause and to help people recover, that you need to look at people who are abused have physical symptoms that need to be addressed in acute care. And it protects, this was really important, that the policy and procedure protects the healthcare workers by giving direction around intervention and documentation. And that whistleblowing protection, it allows a healthcare worker to feel protected that they can act without having to have consequences.
So we had entitled this slide as addressing the gaps, but
yeah, we titled it addressing the gaps, and then Annie and I were reviewing the presentation and going, well, they're not really gaps. Really, they're points that drive home the point that elder abuse intervention is complicated, and it's really complicated to write a clear policy and procedure on something that can be so gray. Some of those areas that we struggled with were having someone take the lead, like a social worker, for example, when you don't have access to that resource. So this is something that acute care hospitals do struggle with. Do you do nothing because you don't have someone who has social welfare within the scope of their practice domain? And we really try to approach that by creating an interprofessional team approach. Capacity, capacity is very complicated for seniors who are in an acute crisis, and we really tried to create, a 3-page document that got to addressing capacity, but yet did not get consumed by issues around capacity. And we recognized, and we wanted to really speak out to say that what is legal is not always viewed as ethical or social justice, and we have different perspectives, and people have different perspectives on what is the right thing to do. So a policy and procedure doesn't replace clinical judgment. It doesn't replace the need to negotiate change, and it will, while providing some clarity for things that are black and white, we still live in a world of gray where there's conflict and the need to use our clinical judgment to negotiate change.
So our ingredients for success, things that for you to consider if you're working on one or you're revamping the current one you have, is that it's about sharing your knowledge and your energy. Getting together with like-minded people that are passionate about this, and that includes from the community sector as well as from the hospital sector and even primary care. And you come up with something that's, it's got to reflect the legislation and your professional obligations, and also reflects what your current resources would be within your own hospital. And don't forget about that patient and caregiver experience. They're quite key, and that was one of the reasons why we took it to our seniors and caregivers in the community. You need an internal champion. Everyone knows this, right? If you want to move through the bureaucratic process of trying to get a policy and procedure out into the hospital, you need those champions. And then that idea about leverage. And then for us, it was certainly part of that was building on that strategic plan that your organization now has, tapping into the values that they espouse to be something that they strive for, and then finding all those opportunities to collaborate will help you find success. And that is it.
Great, thank you so much. That was extremely thorough in terms of the outlining of the policy. We do have time for questions. If people want to pose their questions in the question box along the side panel, I'll try my best to get those addressed by our speakers. So the first question we had was from Tammy Rankin. Just wanted to know if York Region has appropriate emergency shelter for frail elderly.
So I know that certainly Elder Abuse Ontario, there's a chapter here that's trying to strategize around actually having a shelter bed that would be available. Rayanne, I think you may be able to speak to that more. And I do know that our senior safety office.
Oh, we just cut out.
The retirement homes, and they've been able to tap into retirement homes that would be willing to take patients who have been, that need that safe haven. But there, as of now, there's no official bed in the region.
And I think it's mindful to say that the shelters that we do have were created with a domestic violence lens and for a younger population. So the resources that are connected to those shelters may not necessarily be what a frail senior requires. The physical structure of shelters, so for example stairs and assistive devices, you would most likely not find in that type of environment. So there are some very unique needs that a frail senior does need to have to support relocation to shelters.
Yeah, and just to add to that, we had done a webinar a couple months ago around safe beds. So there are a few safe bed programs within the province. I know in Cornwall as well as Northumberland, and I know there's, I think in Wellington, that there are a few that have set up, and a lot of them are working with their local retirement homes to have a sort of a short-term bed available. So I know in Durham region, sometimes they are able to work with their community partners as well. So it's not a formalized program across the province, but I know that we're working region to region to try to establish that. So if seniors are at risk and they have somewhere to go, if the shelter is not appropriate to their medical needs or social needs, that there is another alternative. But it is an issue that needs to be continued to be addressed. The other question we have was from Caitlin Morello from Waterloo, and she wondered if you have a policy and procedures on Form G in the hospital when it deals with consent and capacity. And actually, I came across this in a situation just the other day. So do you deal with that, or do you have that within your policy?
I would have to Google search it in the search button. It's not something that's on the top of my mind. We have a policy and procedure on substitute decision making, but I haven't seen anything specific to Form G. That doesn't mean we don't have it. It's not something that's overlapped with our practice.
Okay. So the second one is from Kathy Roma. Your policy is a focus on elder abuse. Do you have a separate policy for others between the ages of 18 to 60?
No. No, we don't. When we looked at the policies and procedures, we looked at, definitely there's child abuse, which is legislated. So we have those policies and procedures. We don't have elder between 18 and 60. We tried to cover that, the people under the age of 60, by saying that it was specific to adults in the care of another adult who was vulnerable. Yeah. Okay.
Okay. And the next question, what strategies would you recommend in terms of staff education and engagement with the rollout of a new policy?
That's what we're doing right now. So we're engaging right now with the interprofessional. We have an interprofessional practice council, so IPEC. We have interprofessional education rounds, and we have professional practice councils. So that's where we've targeted the rollout of the education. And we also see the nurse educators on the unit as being linkages to the frontline nursing staff. So we've been able to do that like education rounds for people who are interested to come and listen, but in terms of actually ensuring that the people on the front line understand how to use the policy, that's what we're working on right now.
Yeah.
Mm-hmm.
One of the successful strategies in the past that we have done is what we call the traveling roadshow, and that's where two people would go up and they would actually target different units just to try and bring that attention to the staff and kind of tweak their interests. You can have a little chat. You don't have to spend a lot of time, and then you would link them back to the policy online and then to their educator so that they could further explore what their responsibilities are. So that's actually been very successful for other things like delirium. And I suspect that that's something we'll implement in the future moving forward.
Great. So we have another question. How is it addressed under duty to document in the medical chart if the abuse is disclosed in a social work interview and the patient does not give consent to the social worker to share this info with the team?
Mm-hmm. Mm-hmm. That was something that we really had to dialogue around, because there were some policies and procedures that we looked at that said that the social worker didn't have to disclose this. The position we took was that abuse is a team's responsibility. The patient has a team working with them, and it was that abuse would be shared with the healthcare team. So it's up to the person that it's disclosed to explain to the patient that they're working for the hospital. The information that is disclosed to them is something that will be recorded in their medical chart, and to have that conversation with them around why it is important that other people on their healthcare team have access to this information. Again, with frail seniors, abuse impacts their physical health. So we felt that it would not be in keeping with best practices to keep away from the physicians and the nurses and the occupational therapists and the physiotherapists the information that would help them understand how to treat the patient. So we said the healthcare team has access to that information.
Have you had anyone not disclose?
We know that not everybody would, pardon me?
Have you had anyone totally object to that process?
We got to our reviewers. But I think it's important to point out that in the acute care unit at Southlake, we don't have a lot of social workers. So I don't know if we got through the reviewers because there weren't a lot of people responding to that, or so. Different hospitals that have strong, like a more coordinated professional practices might have more to say about that.
Okay.
And if you do, we're always, again, it's a policy and procedure. We are trying to do what's best for our patients, and if you have input, then we certainly would like to know, because we're all about improving.
Okay, so we just have a comment in Hastings and Prince Edward County. They have a 72-hour program, stopover program, in conjunction with the designated retirement homes. So thank you for sharing that. I did know that, but I forgot to mention that. There is a regional understanding, also from Linda Reimer from York Region. She also indicated that there's a regional understanding of referral to DASA, which is the domestic assault, sexual, sorry.
Yeah.
Thank you. somebody just wants to know how to download the presentation. I will send out the links to everybody that's on the list. You should be able to click on the link or click on the actual document, and it should be able to download for you. If not, if anyone's having difficulty with that, I will send it out. It also will be posted on our website in a few days once I have the archived version of the webinar. It'll be all posted onto the information. Also, Peen also has a safe house program in Peel region, and they also provide older adults in crisis with a safe place to stay up for 7 days. During this time, partner agencies will work with older adults to explore transitional or permanent housing options. So we have another question. When you review the Long-Term Care Act, it says that the administrator needs to be notified of any suspected elder abuse. Do you contact the long-term care home when you contact the Ministry of Health and Long-Term Care within your policy?
You know what? That is, again, you need to use some clinical judgment in that, because what we see in the hospital is only a snapshot of the person's life, and you can't really understand if it's elder abuse when people are very frail and cognitively impaired. So part of it may be to contact the long-term care home to get a little more context around what you're seeing in the hospital. And an example of that might be somebody who comes in with multiple pressure ulcers, and you may think, oh, they look like they've never moved out of bed, and so is there neglect here? But you really can't jump to that conclusion without more context, and part of that, getting that, may be to call the long-term care home. Now, if you call the long-term care home, they're very clear on what their responsibilities are, and then they need to, if there's abuse and neglect, then they need to also contact the reporting mechanism person. Yeah.
Great,
Yeah.
thank you. And we have another comment from Tammy Rankin in Durham region. It's time, she makes a comment that it's time for a provincial task team to address standardized emergency shelter protocol for elder abuse victims.
Awesome. Yes,
Totally
absolutely. Agree. We're on board with you, Tammy.
Yep.
Send us an email. We're championing you. we're all working together.
So if I could just sort of add to that, some of the work that I've been doing with the geriatric emergency nurses, which is one of the impetus, I guess, in terms of doing this webinar, particularly, and some of the other work, is that if anybody is interested in pursuing that idea with around that, I would be more than willing to sort of take that lead. And if Tammy, if you want to join, and others, please let me know. I think everyone has my email, centraleast@elderabuse.ontario, and maybe we can strike up a little task force team. That's a great idea.
Yeah, absolutely. Because when you start to go through the best practices, you really realize where the gaps are. And we're trying to make something that is not simple appear to be simple, so that people will do something that are new to elder abuse. But those of us who've been working in elder abuse for a long time know that there's a lot of gray areas, and there's opportunity here to make it better.
Thank you. And there was just a comment too from Tammy. I probably should have commented on that. When you do suspect abuse in a long-term care home, you're not mandated to inform the home that you've made that report, only to the Ministry of Health. So you don't have.
That's true.
Yes. You don't have to do that. So that's great.
And in fact, I would tell you that if we have a senior who comes into our hospital through the emergency department, quite often, if there's been a report made, I will actually get a call from the long-term care home administrator to let me know that that's already in process.
Right, okay.
Right? Mm-hmm. So, which doesn't mean that I can't go ahead and report it as well, but usually that's them saying to me that there's an incident happened, they're sending them to the ER for some acute care treatment assessment, and they'll contact the GEM office to let them know that they've actually done a report and an investigation's underway.
Okay. Are there any other questions that anybody has? This has been very informative. I know for myself, there's been comments that this has been an excellent presentation. from others, so that's good news. If we can just, well, people are maybe thinking of another question, if you could just go to the final slides for me, Susan.
This one?
Yeah.
Is that it?
Yeah. So just to let everyone know that we do have our senior safety line as well, that we do inform older adults in the community that they may be discharged if they're having concerns, if they want to talk to someone in terms of counseling, or they're not sure who to connect with, or they forget who to connect with, that safety line is available as well. We do have our website as well. If people aren't on our newsletter, which I think most people are, you can subscribe on our website on our home page where it says Connect with Us. We just sent out our recent newsletter yesterday. So if it's posted on our website, but we also send that out through our constant contact list, which people get updates on our webinars and events, which we're holding quite frequently now. So we have another one coming up in a couple weeks. So just to keep track of that, that's a great way of keeping connected with us and us with you in terms of getting feedback in terms of how we can work and improve our work in response to elder abuse across the province. And just the last one, I think, is just my contact information. Again, our website, we're constantly adding things. If you have a program or services that's new, we always try to keep up our database of services and programs as well. And we are possibly looking at sort of revising our website. They're an ongoing kind of project, I think, if anybody who does a website. So it's a great resource for individuals to tap into. So I'm just going to go back to see if there's any other questions.
Were we going to revisit the poll, Rayanne?
Oh, yes. So we have one more poll question before everybody leaves. Thank you for reminding me. So the last question, just after the presentation, we just wanted to know if this presentation has inspired you to feel prompted or to feel to promote or develop a new elder abuse policy or procedure within your hospital or agency that you work in. And I appreciate those who have let me know that there's other people within your room or sharing a computer to participate in this. It's really great to find, just to get a sense of numbers and people who are participating in our webinars. So I do appreciate that. We did have over 100 people register for our webinar today, and we had some people who were sort of on hold. So that's great. We know that there's a lot of interest in this field. So the idea of a provincial task force to look at this in a further avenue is a good idea. So I'm just going to close that and share that with individuals. So 47 people said they were very confident, somewhat confident 26, and confident 32%. So thank you so much for sharing that with us. So thank you again. If there's no other questions, I'll just look one quickly again. Most people said it's excellent presentation, and I think that's it. So thank you very much, everyone, for participating. Like I said, there will be a short evaluation after the after you hang up or when we close the session today. And if you just don't mind taking 2 minutes just to fill that in, that would be great for us as well. So thank you again, Susan and Annie, for participating today and sharing your expertise. We really appreciate your participation and joining us for our webinar. Thank you, everybody.
Our pleasure.